NeuroAnatomy lecture. So what is the basal ganglia? What are the basal ganglia? So they're a collection of cortical nuclei. So they're not, although they are small tract and structures, they're not large, gross anatomical structures. They would be difficult to dissect easily. And so they're small nuclei. And what they do is they form part of a basic feedback circuit. So there are multiple functions, modalities to the basal ganglia, which we'll go through. But the important take-home part in this is it's a feedback circuit. So almost concomitant with the fact that you've got the autonomic nervous system with a parasympathetic and sympathetic, the basal ganglia does its own little thing with different pathways competing or working alongside each other in almost a yin-yang fashion to get control and modulation of movement. So a little bit of maybe interesting facts. I always like to start a lecture with an interesting fact or something that makes you remember something. Basal ganglia is technically a misnomer, i.e. it's not a really correctly named phenomenon. Because a ganglia, as you guys all know, could probably recite to me from preclinical time, is a collection of cells that's outside of the CNS. So it's better more to describe this as basal nuclei, i.e. structures within the central nervous system itself. But ganglia has kept since about this, I think the early 60s is when it was properly coined, and even before then, the 18. So we'll keep with that in a moment. So key components. We will be revisiting these words so many times in this lecture and going through the different structures. So the striatum is almost after our motor cortex, if we're talking about motor function. The striatum is our first port of call, and it encompasses our caudate nucleus and the putamen or putamen. Caudate C being C-shaped. Now, the globus pallidus is our secondary part, and it's divided actually into two segments, and we'll shorten to GPI and GPE during the talk. But it's an internal and external part of the globus pallidus. Now, I've got plenty of pictures coming, so those of you who are very visual, do not worry. The subthalamic nucleus is pretty much perfectly named. It sits beneath or in the inferior part of the thalamus below. And then the substantia nigra is divided into two parts. We've got the reticular part, which we won't talk a great deal about, and we'll talk about the zona compacta in particular. That comes into quite important relevance with the clinical sections. So talking about, I haven't gone into the in-depth embryology. Many of you will sigh a breath of relief there. But talking about almost the telencephalon, so the caudate nucleus of putamen, which form our striatum, are sat in this part. So that's the higher cortex frontal area. Now the most rostral part forms our nucleus accumbens. I'm not going to talk a great deal about this. This comes into more of the behavioral and functional elements of the basal ganglia, where we're going to focus particularly heavy on motor systems today. The subthalamic nucleus is the diencephalon, and then down in the midbrain, our mesencephalon, we have the substantia nigra, which we've said is our two divisions. So let's get on to some pictures, just to make it a little easier to imagine our head, what this looks like. So here we've got a coronal section looking through. You can see, hopefully you can see my mouse moving. This is the head of that caudate nucleus. Now, I'm going to have a 3D picture shortly, which will give us a little bit more of a sense of that C shape. But to orientate ourselves, this is our midline. We'll have our corpus callosum coming up top with our septum pellucidum in the midline. Our CSF-filled lateral ventricles, which Mr. Matloob spoke to you guys about right almost at the start of this, this series. That putamen that we mentioned sitting outside here, and the globus pallidus. Now, easy way to remember these three is that they almost form like an ice cream cone. Your globus pallidus being your cone itself, and your putamen being the ice cream on top. So it's a nice little shape there. And it's easy to imagine it this way, and of course you have the thalamus here kissing over the water. So I think it's easier to imagine it in this kind of cross-section when you're going through the order and the pathways, just because they are sat quite nicely together in terms of location for pathways. Again, this takes us back to this picture, a little bit more, less of a cartoony picture here, but not showing you anything we haven't really shown on the previous slide. Now, what we're going to try to highlight here is, I mentioned this caudate nucleus here. This is the head of the caudate nucleus, and this is the tail. It's like a C shape. Imagine it going backwards like this, and then following around and sitting, oh, he says, sitting then in front. So it encompasses around with a putamen sitting on the outside here. And there's a great picture coming up which will show that. So if you can see, this is obviously taking a zoom in there. This is we're looking from a lateral aspect now. This is our C shape of our caudate nucleus. Now you imagine that slice where we could see both the head and the tail. We've taken a cross-sectional slice probably down there to cut to that section there. And you can see we've got the putamen sitting here. If you follow our ice cream cone in, if that is our putamen, we know that we're going to have the external part and then the internal part. You'll sometimes hear it described as lateral and medial. But truthfully, until I wrote this lecture, I'd never actually seen it written like that. I'd always been taught external and internal. So we'll stick to that throughout this talk. You've got your thalamus. And the important thing to take away from the anatomy of this is mirrored on the other side. So sitting across the water, that CSF is a mirror image of this and a picture of that, okay? So it looks the same on both sides. You'll have a left side and a right side coordinating the right and left hemisphere. Good, so let's take it to some imaging just to see that obviously it's not every day that you'll sit on the wall, particularly in your early clinical years, looking for the basal ganglia on a scan, if ever. But it's interesting to see how they sit in terms of different sectionals. So we can see the caudate, that C shape. We can see the putamen sitting out there, and you can really see that ice cream cone that highlighting there. Just remember, ice cream cone, and you'll know a nice, easy way to remember it. For those in the early years, if you have tuned in, it's not uncommon to get these in kind of OSPE examinations, get given a picture of a scan, highlight what part of the basal ganglia is this. It's not so common in later years to get that, but it is important to be able to recognize what you're looking at. Okay, so I've mentioned the nuclei, so it means we're going to have outputs and inputs, i.e. what I mean by that is inputs, so those that have input essentially coming in from other areas. So if we look here, we've got the caudate nucleus and putamen. They're going to have inputs particularly from the cortex, so in one context, the motor cortex. We've then got output nuclei, so these are ones that give outputs to other parts of the basal ganglia or back to the motor cortex or to the spinal tracts. So that will be parts of our globus pallidus and our pars reticulata, which we'll cover later on. Now, in other parts of anatomy, there's almost a huge section of vasculature. What supplies what? The basal ganglia has a rather straightforward point to that. It's only supplied arterially by small striate arteries, lenticulostriate arteries, which come off our MCA. So everyone knows that you'll be familiar with your basal your circle of Willis, having done your session with Mr. Matloob on vasculature. You'll have your ICA, which comes and then divides and gives you your small anterior cerebral artery, your ACA, which will come up and give you your callosal arteries, and your anterior communicating artery. And then off this MCA, as it supplies for the divisions, you will get these lenticulostriate arteries. They're small branching perforating arteries rather than one large artery supplying the entire system. Where there is an artery, there is a vein for the most part. And venous drainage of the basal systems is actually through small striate veins, so thalamostriate veins. You can see that here. This is part of our thalamus, you can see. If we just orientate ourselves, the corpus callosum, our midline is coming down here. So that's our thalamus. And we'll have those small thalamostriate veins, which drain. We'll have small perforating veins drain down into the greater internal cerebral veins, which in turn feed into our vein of Galen, so the greater cerebral vein. So that's truthfully the big summary of our anatomy of the basal ganglia, and it's the important parts that we need to take forward in order to go through our pathways. This summary slide is essentially what I want to take away from this part. So these are the key elements that you guys need to recognize and be familiar with when we're going through the pathways and the functions of the basal ganglia. Because truthfully, the exciting part of the basal ganglia isn't so much its anatomy, though it is interesting. It's actually the pathways and its function and how that clinically represents things. So striatum, globus pallidus, that was our ice cream cone section, and then our subthalamic nucleus, and then down to our substantia nigra, which supplies, of course, our dopamine input into this system. Okay. So a very short part on function before we get on to our pathways. So it's interesting, you may read around the function of the basal ganglia, and truthfully, most books nowadays will talk about the motor component, i.e. the modulatory motor part of the basal ganglia in coordinates with the cerebellum. Others will discuss, of course, emotional and behavioral aspects of the basal ganglia, so diseases which we'll talk about later. And some very old books actually will describe it as a neurologist basal ganglia, a psychologist basal ganglia, and a psychiatrist basal ganglia, i.e. 3 different sections with different pathways with different outputs. We're going to focus on what historically is called the neurologist's basal ganglia. So we're going to look at the motor modulation sectors of the basal ganglia. So we've mentioned earlier, it provides a feedback mechanism to the cerebral cortex. Its importance from a motor component is to start, stop, or modulate and refine cortical activation. Now, what that means by that, it can mean initiation of movement. It can mean be that rapid or actually a slow progressive initiation. It can mean a rapid stop, so a quick change in motor. And then it can be modulating, i.e. do I need a large output from a motor point, or do actually need a small one, i.e. does it need to be a strong movement or actually not such strong movement? So it's basically a tonically active brake, and its main strength is inhibition. So it's inhibitory effect through thalamus, which we'll get to. Now, I've mentioned and touched upon this emotional and cognitive section. Now, you have the limbic input through the ventral striatum, and then you've got the prefrontal input through that caudate nucleus, gives you your cognitive. Now, I will touch briefly upon that in the clinical section, but truthfully, I'm not going to go into too much detail. It is still rather a researched area, and the motor components of the basal ganglia are far better understood than the psychological and psychiatric elements of the basal ganglia. That's not to say they're not important in any sense, but given how the basal ganglia, people have based decades worth of a career on one section of the basal ganglia, I did not think 45 minutes covering all 3 of these to a significant level would do justice. So we're going to stick with our motor. Perfect. So that's our motor circuit that we're going to go through. We're going to, as we go through the pathways, we're going to look at this part in particular. And then we're not going to go into the associative or limbic circuits in particular. I think they will warrant their own talks at some other point. Okay. That takes us neatly on to the main bulk of this talk, and actually the key important areas. So most neuro lectures or neurology or neurosurgical lectures in med school tend to be met with either those who are immensely keen on neuro or those who have a slight neurophobia. And I think the basal ganglia has a little bit of part to blame for that, if I'm honest. The pathways, be it indirect, direct, already sound a bit confusing. And when you go and mix in words inhibitory and excitatory every other word, it gets a little bit complex. So we're going to spend plenty of time on this and break it down. And I've got a mixture of almost images that are very visual and then those that are a bit more structural. So we can kind of try 2 different ways at that. If at any point this is not making sense, if the chat function is working, you can flag up to somebody or save it to the end, and I'm happy to come back and we can go through it in a bit more depth with everyone. Or go over it again, because this is the main bit that we need to take away from this chat, this discussion. Okay, so this slide, you're probably going to see this slide 3 or 4 times over the next 20 minutes, because I think this is one of the most important slides to get into people's minds. So the direct, we've got 3 or 4 key pathways when it comes to motor, 3 in the way I would word it. So we've got a direct pathway, an indirect pathway, and then a hyperdirect pathway, which actually is rather straightforward. Now, there's some books will describe the nigrostriatal pathway, i.e. the dopamine modulation of this pathway, as a separate entity. I think it's easier to think about the dopamine input from the substantia nigra as actually part of both the direct and indirect as a different function. And I'll explain what I mean by that. It's just, it does not make sense to think of it as a separate pathway because it's not happening completely independently. It's not that it's never there, unless you have a disease where there is no dopamine, which might ring a few bells for a few people, hopefully. There's not going to be a situation where you're not having that ongoing on and off. So I think what we're going to do is going to talk about it at the same time. Additionally to this, if we look at the key neurotransmitters, we've got 3 ones which we're going to mainly touch on. 2 in particular, which is GABA, glutamate, and dopamine. I'm going to talk a little bit about that shortly. This will bring flashbacks to anyone who's now year 3, 4, or 5 med school or postgrad. This will take you flashbacks to sitting in the lecture theatre, looking at ligand-gated channels and multiple things that will bring back nice memories, I'm sure, for everybody. But we're not going to go into too much depth, just to reassure people we are, but we do need to be aware of what they do and why they're important. So that takes us nicely onto here. We've got GABA and glutamate. Now, both of these within the basal ganglia lead their effect through a ligand-gated ion channel effect. So GABA, so your GABA aminobutyric acid. Now, I've simplified these quite significantly, but the main point of it is what you'll have with GABA. GABA is naturally an inhibitory neurotransmitter, i.e. it will stop the effect of whatever it's having an effect on. It inhibits whatever it's affecting. Glutamate in blue is the opposite. So glutamate will excite anything. So i.e. if a neuron after that glutamate's affecting is an excitatory one, glutamate will excite it further. GABA will inhibit that excitation. So GABA does this by an efflux of positive ions. So if we think of things like potassium or sodium, but potassium in particular, and then we get an influx of negatives, things like chloride. What you end up doing is you get a net negative effect on the net negative collection with interneurons. So what you end up getting is a lowered resting potential. So if we're taking ourselves back to resting potentials, threshold potentials, and then action potentials. So if you lower the resting potential, you're going to go well below threshold potential limit. And so you're not going to have an excitatory effect of that. No, you're going to inhibit whatever's going on. Glutamate does quite the opposite. So you get an efflux of these negative ones. So we'll think of things like chloride again. And you'll get an influx of positive things like sodium, potassium, calcium in particular. And you'll get an increased resting potential. And that, over time, if you do it enough, will overcome any threshold potential. You'll overcome the action potential requirement, and you'll get an excitatory effect. Sorry, that's me just taking a sip of tea. I encourage everyone to have a beverage of some kind with them whilst we're going through this. So we get an excitatory effect with glutamate. So the important one, GABA, glutamate. GABA in red, which I've tried to coordinate with the pictures we've got next, will inhibit. Glutamate will excite. Okay, so let's start with the direct pathway. If we remember back to that slide earlier, the direct pathway is to disinhibit the thalamus, so i.e. to stop the thalamus from being inhibited and to give us a motor output. So the direct aims to move. This is the kind of pathway that you're thinking about if you reach to pick up a pen. This is the kind of pathway that comes into play. If you're going to run, if you're continuing to run, this pathway is constantly in all. So if we take our first step, so all these slides I've got coming are linked in that they're from a similar source, which I can give. I'm happy to give people resources if they need any. So step one is our motor cortex. This is where we're going to say everything begins. This is where we get the higher order function to say pick up a pen. We'll call it picking up a pen. So the motor cortex will give us an excitatory via glutamate onto the striatum. Remember our caudate and our putamen here. As you've got your caudate, you can see there, putamen outside here. That forms our neostriatum or striatum, and that will excite the striatum. Now, the striatum's natural function is to inhibit this globus pallidus internus. So the globus pallidus internus, part of the globus pallidus that we saw earlier and we discussed earlier, the ice cream cone, is known to inhibit the thalamus at natural baseline. So if this is allowed to do what it normally does, it inhibits the thalamus from giving positive feedback to the motor cortex to initiate a movement or to continue the movement and give an excitatory to the motor cortex. So if we've excited the striatum, whose natural way is to have an inhibitory effect on this GPI, this internus, we are exciting the striatum to inhibit it. So we're telling the striatum, yes, you're going to increase the action potential along this inhibitory line. So you get an excitation which forces the striatum to have its negative effect on this internus. So if that's happening, you can see here that inhibition that would have naturally happened from the globus pallidus internus is blocked, because what you've got is a negative block blocking this negative. So it's a double block. So a inhibition blocking an inhibition, which is called a disinhibition. You're basically getting rid of this inhibitory effect because you're unexciting it. Now, because of that, you've released the thalamus, which will have an increased activity to the motor cortex, and that will continue the motor loop. So just to go through that again, because this is our baseline movement. So motor cortex, you get an order, you're going to pick up a pen. You get glutamate, our positive excitatory neurotransmitter, which excites the striatum. The striatum's natural modes are to be a inhibitor, so they naturally inhibit a GPI. Through GABA being released in the striatum, GABA inhibits whatever action the GPI has. The GPI's natural action is to inhibit the thalamus. So you get what's called a disinhibition, an excitation which causes inhibition of the GPI, which would naturally inhibit the thalamus. So disinhibition, and that lets us have a movement. Now, dopamine comes into this. You can see you've got the subthalamic nucleus here, your substantia nigra, and that's actually the zona compacta, sorry, excuse me. Now, there are two receptors that dopamine act on within the basal ganglia. There are obviously D1, D2, D3, and further in the system, but D1 and D2 are the ones we're going to focus on. D1 is an excitatory neurotransmitter, a excitatory receptor. So if we're having dopamine act on D1 receptors in the striatum, which is excitatory, just like we have this glutamate here, that dopamine excites the striatum further. And that kicks in an additional inhibition of the GPI through GABA. So what you're getting is, if your baseline is just the glutamate from the motor cortex giving that excitation to the striatum, add in dopamine, you actually get an increased surge of motor output at the end again, because you've actually inhibited the thalamus via the GPI further, because you've had both the effects of glutamate and the effects of dopamine. So why is this important? This is particularly important in modulation of a movement. So a big movement versus a small movement, heavy object, light object. Motor cortex has one input. Dopamine is your secondary input to further strengthen that signal. So you have both glutamate, both dopamine, activate the striatum, which has an inhibitory effect on the globus pallidus internus. So you disinhibit the thalamus because you block the GPI's natural inhibitory effect. Now, I apologize if I've gone through that so many times that it's you're bored of it on the second explanation, but I think it's just important to make sure that we've got this down. That takes us on to the indirect. So if we direct disinhibits, i.e. direct creates a motor movement, the indirect inhibits. So it's going to stop the movement in its natural form. So we're going to ignore the inputs of dopamine at the moment. Put that aside, ignore those arrows. The blue arrows are excitatory again, the red arrows inhibitory. So our big step, motor cortex. We'll say the indirect pathway, the important part about this is to remember that indirect isn't so much as to stop a movement, but it's also additional to prevent a movement, i.e. to stop unwanted movements. And that can be from movement disorders, or it can be from reflexes. So if we go down and hence see, the motor cortex is given, say, a movement, and we've got a glutamate onto the striatum. So that naturally, in the indirect pathway, has a negatory effect through GABA on your GPE, so the external part of the globus pallidus. Now, the globus pallidus, as does the GPI, naturally has an inhibitory effect. Both the GPs have inhibitory. But instead, unlike the GPI, which goes straight to the thalamus, the GPE has connections to the subthalamic nucleus. Now, what we've done is, because subthalamic nucleus naturally uses glutamate to excite onto the GPI, we have stopped the block that GP would normally have through the striatum. So that GABA, you can see this one coming down here, has blocked this negatory effect that GP would naturally put on the subthalamic nucleus, which means the subthalamic nucleus, this connection here onto the GPI is going to be firing at full, which means we're going to get this excitatory effect of the globus pallidus internus. Think back to our direct pathway. Our globus pallidus internus connects onto our thalamus. Likewise here, that's equally true here. What you end up getting is, because you've got that excitation from glutamate from the subthalamic nucleus onto the GPI, which naturally inhibit the thalamus, this inhibition pathway, which we blocked before, if you guys remember, is now active. And not just that, it's encouraged to fire because of the glutamate effect on the GPI. So what we end up getting is actually this excitation onto the GPI that blocks the thalamus and stops movement. So it's not a disinhibition, it's a truly inhibitory effect from the thalamus, which is what it would naturally do with the globus pallidus internus. So we get a glutamate from the motor cortex onto our natural striatum, naturally inhibitory striatum. That gives, through GABA, an inhibition on the GPU, on the globus pallidus externus. which in turn, because it usually would block the subthalamic nucleus, is no longer going to block the subthalamic nucleus. That means the subthalamic nucleus will be free to excitate the globus pallidus internus. And that, which normally has an inhibitory effect on the thalamus, is free to do so. So the indirect pathway inhibits the thalamus through excitation of the globus pallidus internus. So just to compare those two, the direct pathway, a little bit more straightforward, has that excitation which then directly excites the striatum to block the effects of the GPI, meaning the thalamus is free to have more activity. This way it takes a slight loop round in that it goes through the GPE first, blocking the GPE's effect on the subthalamic nucleus. The subthalamic nucleus is then free to excite the globus pallidus internus, which in turn will then block the thalamus. So the thalamus then does not have any excitatory inputs up to the motor cortex. Usually this is a perfect place to stop and check everyone is on board. But what I'll do is I'll finish the hyperdirect pathway, and then we can possibly do that before we go moving on, because I think that might be a nice reasonable part to stop. Can I check actually with the moderators, is the chat function working or is it not working tonight?
It's not working, but people are free to raise their hands.
Perfect, okay.
Usually we have people raising their hands and asking.
Perfect. Do we have many hands at the moment?
Currently, no, but they are absolutely free to do so.
Perfect, okay. So that will either mean that everyone is perfectly understanding this and I'm teaching people to suck eggs, or they've not put their hands up. Please, if this does not make sense, put your hands up and we'll go through it again. And we'll address any concerns, because this truthfully is the main bulk of understanding the basal ganglia. And if you can get this down, then you can understand nearly most conditions that affect the basal ganglia will make more sense, because it's a first principle effect.
We have 2 people who've raised their hands.
Ah, fantastic. Out of 40 odd, that's not too bad. So what we'll do is we'll finish this part and then we'll go to what those people want to kind of go through. The hyperdirect pathway. So the hyperdirect pathway is a very straightforward pathway that acts to inhibit movement. So this is your pathway that you'll probably activate if you want to do a very sharp, quick correctional movement. So examples that are sometimes given are emergency stops, or quickly withdrawing a hand, which is in a non-reflexual spinal fashion. So step 1 again is our motor cortex. We'll have that glutamate, the positive, the excitatory effect on the subthalamic nucleus, which naturally also excites the GPI. So if you remember, that is still true of what we learned in the indirect pathway. The subthalamic nucleus's connection is the GPI and it's positive. That, in turn, will activate the GPI's negative effect. On the thalamus, it blocks the thalamus. So it's very similar to the direct pathway, in that, but the only difference is it goes directly, the motor cortex skips the caudate, the neostriate, the caudate, and the putamen. It has no function for it at all, and actually just goes straight on to the subthalamic nucleus, and then go on to the GPI. So that is for very quick, hyperacute correctional movements. So movements which need to be sudden and are not very well modulated through a dopamine effect. Okay. For those of you who do not like that kind of setup, i.e. looking at it from a cross-sectional, I know that does not suit everyone's way of learning. We have this way, which is actually the way I was taught it in med school initially. And it's, for some people, this will be a far more visual and easy way to learn something. So very similar to before, cerebral cortex is our starting point. We've got our glutamate, our excitatory on the striatum. If we're taking our direct pathway, so we'll look here, remember those D1 receptors, which are excitatory, this up on the substantia nigra. That will make sure our striatum has the negative GABA effect on the internal globus pallidus. The internal globus pallidus had that negative effect on our thalamus. Don't worry about this. These are the 2 nuclei within the thalamus that we're talking about. And that, in a sense, will then disinhibit to give you a glutamate on the cerebral cortex. Okay, so I personally find the brain slides previously a little bit easier to understand, and visually makes a bit more sense. But for those of you who this works, if it works, it works. Now, what we will do, there's one thing we haven't talked about, and that's actually the modulation of movement that dopamine has in the indirect pathway. So remember, the effects of dopamine is to create a movement. So think of a condition in your head, which we will touch upon later, where dopamine deficiency causes an issue. In the indirect pathway, dopamine's aim is to try and cause a movement, even though to overcome the indirect pathway. Now, the truth of this is, we said earlier, the indirect pathway is to avoid unwanted movements. So it's to almost quiet down and dampen unwanted movements. So it's not always true that this dopamine will create a wanted movement. It may be that over dopamine, which is a clinical case, if you give someone too much dopamine, you can get unwanted and unwanted movements. So if we again follow our indirect pathway, motor cortex, we go down to the striatum, which is being excited through the glutamate. At the same time, you have D2 receptors activated, which are dopamine 2 receptors. So unlike the D1 receptors, which are excitatory in the direct pathway, in the indirect pathway, they're inhibitory. Okay, so that's not subthalamus, apologies. That compactor, the zona compactor, will give you the dopamine, and they'll activate dopamine 2. Now, what I want you to imagine is every arrow, unfortunately, I attempted to do some art to make this work, but it just did not do what I wanted to do. If you imagine every arrow from this point onwards in reverse. So because you've got this D2 effect from the dopamine, you're actually going to inhibit the striatum. So rather than being excited by the motor cortex, the dopamine from this pathway activates the D2, which gives you an overall inhibitory effect on the striatum. So this arrow here that passes all the way down would actually become like that dotted line, and it's no longer going to have an inhibitory effect on the GPE. So instead of inhibiting the GPE, the globus pallidus externus, is now free to do what it naturally would do, and that inhibits the subthalamic nucleus. Now, if the subthalamic nucleus is inhibited, we're no longer, opposed to this, we're going to get a decrease in activity. And now when that happens, what have a, I think we've got some visitors. What you're going to have, instead of having an excitatory effect on the GPI, you're going to have no effect on the GPI. So because this is deactivating the STN no longer will excite the GPI. Okay, and without that GPI being excited, we're disinhibiting it because it's not going to have an excitatory glutamate. The thalamus is not going to be inhibited by it. So to say that again, imagine this arrow is blue. It's excitating this, meaning this arrow goes full red because it blocks the STN. This arrow becomes red. It's now no longer excitating. It's not inhibiting, because it's not what it naturally does, but it's not exciting it. The GPI, then this becomes a dotted because it's no longer in play. So the thalamus is now free to do what it does. This arrow will become blue, and the thalamus will create a movement. Okay, so that's actually a bit more complex than the dopamine effects. But what the key parts of the dopamine is, remember, in the direct pathway, we have D1 receptors. In the indirect, we have D2. And the aim of both, or result of both, is that it will create a movement, i.e. you'll force a movement. Okay. And that takes us back to that slide with a summary there of what we've said. So direct disinhibits the thalamus, you get movement. The indirect inhibits the thalamus, you get no movement. And then that modulatory effect of dopamine in the direct pathway will give you bigger movements on top of what you already got. And in the indirect, creates a movement where you would not have one. And then the hyperdirect pathway, you've got a rapid and an override of what's going on. So i.e. I need a sudden stop. Okay, I think that's probably a good little bit to pause. Do we have any hands and any particular questions, or there's one section we want to go over again that I haven't made clear?
If anyone has any questions, please feel free to unmute and ask them. So Shay, please ask. Amira, would you like to ask a question?
Yes, thank you so much. I am mostly with you so far, but can I just check? So just the indirect pathway can be both inhibitory and excitatory, but does that depend on whether or not dopamine is involved. I'm a little bit confused as to
Yes.
how it's
No,
indirect and how it's inhibitory and how it's excitatory. What decides that? Sorry.
Yes, no, good question. At its baseline, if you have no input from the reticular part, the zona reticularis, i.e. the dopamine input, in its natural form, the entire function of the indirect pathway is to inhibit a movement, i.e. dull down background movements that should not happen. So at its baseline, without dopamine's input, you will have no movement or should have less movement. Does that make sense?
Okay, that makes sense, yeah.
Yeah, whereas the second dopamine's added in, dopamine in both systems will work to encourage or facilitate a movement. So in the direct, we just create a bigger movement, which is actually beneficial. It's what we want. And it's one of the main modulations of the dopamine system. Via the indirect pathway, that can work in multiple ways, but truthfully, usually it's the dopamine's effect on D2 in the indirect is usually less desirable because the entire point of the indirect is to inhibit unwanted movements. So you're likely to get those unwanted movements then that you would normally be dulling down for the indirect system. The next question you could ask is, when does dopamine know exactly D1, D2? And that all comes from motor cortex instructions, i.e. initiating movement, or is it a movement that should not have happened in the first place? Does that make sense?
Yes, it does. Thank you so much.
Good. So if no one else has hands up, or is there any more hands, is everyone happy to say they can kind of, in their head, understand what the direct and indirect pathway are? Please raise any questions if you have any at this point, because I don't want to move forward if this is kind of our core part of the talk.
No more hands up.
Okay, perfect. So we're either all asleep or actually we get the basal ganglia, which is more likely, I think, which is really good. So we will come back to this again because I think we were talking as moderators and myself before we let you guys in, and it's so easy to do this lecture, feel on fire and absolutely great at the basal ganglia, and then you sit down after you've logged out your computer and try and draw it out or do something else, and you realize it's gone straight away. So I will kind of zoom back to this again and just review it because it is so easy to forget, but so easy to understand once you're just looking at a picture like this. And then you get given an exam question right in front of you and your brain freezes. So we'll go through it again at some point. Okay, so clinical. We're going to go through a pretty short section on clinical, actually. So in the final aspects of our talk for the evening. Because truthfully, there's only a couple of conditions that are really properly understood and probably have manageable functions to do with the basal ganglia. So we have one of our key ones. So this is a condition that I've been hinting at throughout the entire talk. So Parkinson's disease. For those of us, or those of you in medical school, this will be one of your key conditions when it comes to your neurology sections and your clerkings. It will be a key examinable section for you. For those of you at, for example, Imperial, I know, having had input into the OSCEs, that Parkinson's is a fairly common, fair game condition to give you. Having done a neurology job there are plentiful of patients you can examine. And the same is true for Barts. And those of you, if there's anyone from George's, as a George's graduate, we had plentiful of these I had it in my OSCEs in 4th year. So this is a very fair game condition, which I think everyone should know like the back of their hand. So I've got the key symptoms here. So they often present as obviously rigidity, tremor, the postural deficits, and then the linked emotional cognitive issues they have with it. It's truthfully a worryingly common condition amongst the population. It affects us in our later years. And truthfully, by the time you're over 60, it's actually 1 in 100, which is, when you imagine how many people above the age of 60 anyone will see on an acute take, that's quite a lot of people. So why are we interested in Parkinson's, particularly when we're talking about the basal ganglia? So imagine everything I've been saying about the direct and indirect pathway, actually, so direct and indirect. Think about what we've said from a dopamine point of view. So we all know that Parkinson's is characterized by that degeneration of the stamata nigra, so particularly in the zona compacta, which means we have less input from dopamine and sometimes none. So very little dopamine input. If you imagine from that modulatory point of view in the direct pathway, take away that dopamine input, and actually you don't have anything that's driving a further greater effect on movement. you're just relying on baseline glutamate effects on the striatum. So you have no way of modulating the effect of the direct. You have no way of increasing an amplitude. You have no way of further movement. And actually, it explains our difficulty in initiating that movement. So we have, as we were saying from here, so if we look at our zona reticularis, zona compacta, sorry, down on the dopamine effect input into the striatum, if you take that away, you're relying on this glutamate input into the striatum with very little output otherwise. So you're going to have a much less effective and much less efficacious direct pathway. Consequently, the rigidity and then other symptoms come from the fact that we have an indirect pathway concern. If you take away dopamine and that inhibitory effect that we were just going through, if you take away the dopamine input into that, what you're left with is what the natural indirect pathway does, which is inhibits the thalamus. So that also is not going to help you with any form of movement. We're not obviously bringing the hyperdirect pathway in because that has no neostratal, i.e. dopamine input into it. So it goes quite far to explaining what our main management of these conditions are. So if we think about what we would naturally treat, when we look back at the start of, or the history of neurosurgical or neurological input into Parkinson's, people would often have things like thallotomies, so intentional damage to the thalamus, because it'll stop you. If you think in that direct pathway, you don't need to disinhibit it, so you've always got a outward effect onto the motor cortex. You've got no way of being disinhibited from the indirect. That obviously has risk in itself. It leaves someone hemiplegic, but leaves them without the bradykinesis and tremors in particular. Now, then came the discovery or the input of levodopa or synthetic dopamine input. Now, that completely changed how Parkinson's was managed in the early stages. And truthfully, neurosurgery in that form very much took a backseat and almost completely faded out of existence in the management of Parkinson's. It was soon realized, however, and quite quickly, that levodopa works for a good portion of patients with Parkinson's, but over time that effect can change. Some people do not respond at all, and some will still be left with quite debilitating symptoms regardless of dopamine input and dopamine treatment. So functional neurosurgery, for those with an interest in, has over the last few decades made quite a resurgence back, and it's actually Parkinson's is one of the key now conditions that neurosurgery see in terms of functional elements. So the new target for this has actually been the subthalamic nucleus. So looking at that, which is our excitatory effect on the GPI, i.e. the bit that usually inhibits the thalamus. If you imagine that you do purposeful damage to the subthalamic nucleus, you're no longer going to have that inhibition from the GPI. So the thalamus is free. On top of that, there's now things like DBS. So many of you may have seen or heard of deep brain stimulation. I'm not going into in depth in that in this talk, but they're ways of exciting different nuclei within the pathway to excite and then create movement. There are still ways you can do, and with that DBS, there's still multiple targets that you can do with that. So in Parkinson's, the main target for DBS, of course, is the subthalamic nucleus. The thalamus is no longer much of a target so much in Parkinson's. It can be done, but it's mainly for the tremor aspect, not the other symptoms. The thalamus is particularly good for the tremor. So actually people with essential tremor, i.e. not Parkinson's related, but an essential baseline tremor can benefit from DBS in the thalamus, and that is approved for use. And then we've got some like dystonic syndromes, which mainly come from effect in the pallidum, and they are approved for DBS use. There are other conditions which are currently being researched in DBS. DBS is a growing field, and there are things like obsessive compulsive disorders, things like major depressive disorders, and epilepsy. Now, they're all at present within trial, and people are free to correct me. I'm not a functional neurosurgeon, but they are not currently in frequent use. Epilepsy is slowly building actually a little bit more, but the key ones for DBS is in Parkinson's and tremor right now. And it's not uncommon to have people also big centres, for example, Oxford, and then in London, we have very few good number of patients doing that. That takes us on to almost the opposite arm. So the hyperkinetic disorders. So many of you, and I hope most people within their 4th or 5th years should be able to reel off quite a few details about Huntington's disease. So it's a hereditary disease on the Huntington even gene, which is on the short arm of chromosome 4. Now, what happens with the protein delineation in this is you get striatal neurons becoming dysfunctional, and they degenerate over time. Now, I've got a pathway image which we can go through shortly, but it's a bit easier. And the fact that you have, remember the striatum, which is the caudate, and the putamen, are responsible for having that inhibitory effect going out to either the globus pallidus or down to either internal or the external. So without that effect, you can have these unwanted movements, and many of you will recognize that as chorea. Hemibolismus then is repetitive and immensely large involuntary movements of the limbs. So uncontrolled, and they are the ones that you would usually want your indirect pathway to be managing. So your indirect pathway should prevent those kind of movements. And hemibolismus is responsible from a degeneration at the subthalamic nucleus, which again, we'll look at our image and we'll explain why that's the case. Now, the other thing to consider actually on top of all of this is that there are multiple neurodegenerative diseases which can cause these problems. So the list is long of what can affect the basal ganglia, but the key ones I think that I wanted to get in just within a very small time frame of this discussion are Parkinson's, which is a key one, Huntington's and hemibolismus disorders. And we'll briefly touch on this one, just because it's a bit of an interesting one and still very much not fully understood. But the families of the obsessive compulsive disorders, the Tourette syndrome, the ADHDs, are all thought to have an element of basal ganglia dysfunction. And it seems to suggest that there's an over-connection between the caudate and the prefrontal cortex, i.e. over-excitatory effects with no pathway control on that. So it's something to be aware of, that is still a very evolving field. I'm not going to go into much more detail because truthfully, I spent a good while scouring the papers, and actually the literature is still very much in development. But if there are anyone who know my luck, there'll be someone here doing a BSc in this, and then they'll have a great project on it. So please feel free to educate me on that if you want. So this is, be honest, I'm not a huge fan of the way this is set out, but it was a nice picture with comparisons next to each other. So right on our far left, we've got the normal input, so of the basal ganglia, which we've gone through the direct and indirect pathway. It's a bit more of a simplified picture. Some people might like this a little bit more, actually. Now, if we're talking about Parkinson's, right down here, we've got that motor cortex, that normal excitatory effect first. With here, we do not have the effect of the substantia nigra with either D1 or D2 receptors, which means that normal direct inhibition of the GPI through GABA is lost. Equally, that indirect inhibition and that stop of inhibition that we get from the D2 receptors is lost as well. So what we end up getting is we don't get that extra excitation that we discussed in the direct pathway, and we don't get the overriding excitation that we get from the indirect with dopamine, which we went into a little more detail earlier. Now, Huntington's, we don't have that indirect pathway, we lose it at the striatum because of the degeneration, which means we don't get the excitation of the GPI, and we get this unwanted movement because the thalamus, the VA nuclei there, are allowed to overly excite the motor cortex without any reason. And hemibolism, that subthalamic nucleus is now the problem. So although it's being, you've got the normal inhibition, you've got no function of the subthalamic nucleus to excite this here. So without the excitatory of the GPI, that VA, just like in Huntington's, that VA is released to allow output into the motor cortex. So the thalamus is allowed, and it gives you involuntary movements that you do not want. So that's a useful little slide to just compare. So it might be with sometimes screenshotting things or grabbing if that's useful for you. And actually, sometimes people prefer this kind of layout for actually learning the normal pathways in the first place. Those of you that create very small online notes, pictures like that are very useful to slide in. Okay, so that takes us on to, truthfully, the end. Now we're going to do a bit summary. This is a nice little slide, I think, and it's just to summarize nice of what the direct, indirect, and hyperdirect pathway is, and then why and what we have in terms of modulation. So direct pathway, we've said the type is it's excitatory naturally. D and D, it directly is disinhibited. So the pathway is the cortex, the striatum, the globus pallidus, into the thalamus, and then back to the cortex, and then obviously down to the spinal cord. And the function of that is just to initiate a movement. The indirect is opposite, and the aim of it is to terminate a movement or prevent a movement in the first place. And that hyperdirect is to stop a movement. So the function of that is either a large, overly unwanted movement or a baseline inhibition in keeping and in helping with the indirect pathway. And then obviously the clinical aspects we have discussed. Now, I said I'd show you this slide probably 3-4 times. I think this is probably the third. This is the slide to take home, as well as the pictures of the direct and indirect pathway. The direct disinhibits, the indirect inhibits. And then the key neurotransmitters to take home are GABA, which is inhibitory, glutamate, which is excitatory, and dopamine, which is either D1 exciting or D2 inhibitory. And then obviously the hyperdirect pathway. So that takes us on to any questions. I'm happy to, I know we're reaching just about 7:30 now. I'm happy to go back through any of the pathways or any questions, or even if it's just any general discussions of what people have seen or experienced from a ward point of view or what they've learned about basal ganglia. Equally happy for any other discussions from anyone, even if it's not related to basal ganglia, it's just neuro in general. If those of you on Twitter, if you are interested in either neurosurgery, random cooking tweets, or pictures from the Royal London 14th and 12th floor with plenty of filters on, feel free to follow me on Twitter. I will follow you back. Equally, that's a great way if anyone wants advice for, be it future applications for jobs or even academic foundation programs or discussions like that. I'm happy to discuss anything with anyone, and send me either an email or a tweet. I can give you emails if you guys need it. So yeah. Thank you guys, and I hope that was helpful. Any questions, I'm happy to discuss and answer as best I can for you. And I guess the final thing to say is thank you to the guys who are organising and moderating this. It is such an excellent idea. In the particular pandemic time, there is not a great deal happening in conference-wise, and so things like this, having a Neuro Tuesday is great. I've unfortunately, due to on-call commitments, only managed to get into 2 of them previously, but they've both been excellent. So well done, and I think it's very beneficial what you guys are doing, so kudos. Thanks, guys.
Thank you so much, James, for that. That was excellent, and has definitely supplemented a lot of my knowledge on the basal ganglia.